Hello, everyone. Today we have with us one of the eminent doctors from Delhi, Dr. Professor Rajesh Taneja. Dr. Professor Rajesh Taneja is Senior Consultant Urologist, Andrologist and Robotic Surgeon in Indraprasth Apollo Hospital, New Delhi. Dr. Professor Rajesh Taneja has rich experience of 36 years in the field of urology and robotic surgery and carries out the treatments with utmost precision and efficiency, ensuring that patients' health is in safe hands. Today, Dr. Taneja would be speaking with us on interstitial cystitis. We welcome you on the Forbes platform, sir.
Thank you very much, Dr. Gulshan. It's really a pleasure to be introduced like this by you. And it is a pleasure, and I'll be here to answer all your questions.
So we will go ahead with the question answer session now, sir.
Yes.
So, sir, what does the name interstitial cystitis mean? Actually, doctors have now started calling it the bladder pain syndrome or the painful bladder syndrome also. So could you just throw some light on this?
Yes. So interstitial cystitis means inflammation of all the layers of the bladder. So the layers of the bladder are the outer serosa, the inner mucosa, and the muscular layer together. And that whole thickness of the bladder is supposed to be inflamed. And that is how the term interstitial cystitis was coined almost more than a century ago. So what had happened is that we kept thinking that there was a disease in some persons in whom we would find inflammation in all the three layers. But slowly we realized that there were other diseases, other conditions, in fact, which would mimic a painful bladder. For example, when we say bladder pain syndrome or painful bladder syndrome, we are actually trying to say that the pain is coming from the bladder. So it is perceived to come from bladder. For example, if a patient says that when my bladder is full, I have pain or discomfort, and I need to go and visit washroom to evacuate the urine so that my pain disappears. So this is what is the basic definition of bladder pain syndrome. Now, if you have a bladder pain syndrome and the cause is inflammation of all the three layers of the bladder, then it becomes interstitial cystitis. There may be other causes leading to the bladder pain. The other causes which can lead to bladder pain could be, a neuropathic pain, which is coming from the lumbar canal, spinal canal. It may be coming from the pelvic floor. So if there is an overactive pelvic floor, or if there is a dyssynergia between the bladder and the skeletal muscle sphincter, then perhaps we are looking at a situation where the patient presents as bladder pain syndrome, but if you look at the pathology in the bladder, it appears to be absolutely normal, and there is no disease in the bladder, even on cystoscopy or biopsy. Now, that is why, if I were to clarify the two terms, interstitial cystitis actually means inflammation within the bladder, all layers of the bladder, which has caused all these symptoms, whereas bladder pain syndrome is a much wider term in which interstitial cystitis forms one part, and there are other ways, other reasons for these symptoms which are being felt by the patient.
So they say that it takes very long to diagnose this condition. Why is it so?
Yes. So it is, your eyes will see what your mind knows. So it is, for example, if I walk into the kitchen and to make a cup of coffee, and I keep looking for coffee and I won't find it, and my wife will come immediately and locate the coffee for me. So it is because my mind doesn't know where the coffee is lying. And that's how my eyes will not be able to see it. It's a very common phenomenon. So similarly, the doctors who are not used to seeing these patients will miss the diagnosis.
It's not tuned that way, basically.
That's right. So I will tell you the story. The usual situation is that there is a woman at home and she has pain and she cannot tolerate that pain. So she has learned that the pain will go away if she passes urine. So imagine their bladder is like a balloon and there is a wound in the balloon or an ulcer in the balloon. And when it fills up with urine, there is stretching of the wound and stretching of the ulcer, which causes pain. Now the person has learned that if she passes urine, the bladder deflates temporarily and the pain can be controlled. So as a result, these patients, they keep going to the washroom maybe every 20 minutes, 30 minutes, an hour, whatever, varying depending upon the severity of the disease. So some people would go 60 times to the washroom in 24 hours, 60. Imagine their plight. They are talking like me and you, and suddenly they have intense pain. They have to go to the washroom to relieve. So it is called forced frequency. So imagine a woman is there in the family. She's the wife, she's the mother, she's a daughter-in-law, and the kids want to take her for a picnic. She says, I don't want to go because I cannot travel in the car for say maybe 45 minutes. She cannot go to shopping. She doesn't want to go to any family functions. She does not want to go into any gatherings. So what is the story that is picked up by her mother-in-law? So she says this is an antisocial woman. So she tells the husband or her son that, look, your wife is antisocial. She doesn't mix up with the relatives. And you look at the kids will say, okay, mom, let's go to the park for playing. I want to play. Everybody's mothers is there. So she says, no, I cannot come. So they start hating their mother. The other problem is, since the pain is in the pelvis, she cannot have normal relationship with her husband. So husband thinks that this lady is really faking because he can't find anything wrong with her physically. And she says, stay away from me because it is painful to be in relation.
Right.
So this woman is then taken to a general practitioner. And a general practitioner who is an MBBS doctor thinks that she has got frequent urination. So what is her problem? It is presented as frequency of urination. That I need to go to washroom. So he says, okay, maybe it is an infection. So he gives an antibiotic empirically. And there is nothing. Then you get a urine test done and that is nothing. Then the GP gets an ultrasound and the ultrasound apparently is normal. That is when they say, look, your family member is perhaps, everything is in her mind. She doesn't have a disease. She's just a troublemaker. Whereas this woman is actually suffering. When she goes to a mall, the first thing she has to look at.
This is how the diagnosis gets missed, basically.
Yes. So she goes to a mall and she looks for where is the washroom. And she stays close to the washroom even if she goes there. So then the next person is the gynecologist. The GP refers them to the gynecologist. And the gynecologist examines and sometimes say, it's okay, gives more antibiotics, more painkillers. Sometimes they'll find an excuse to do a hysterectomy. So these patients, they land up with a hysterectomy, an unnecessary removal of the uterus, because the gynecologist feels maybe the pain is coming from the uterus, and if I remove the uterus, her pain will go. In all good faith, she does a hysterectomy, but the pain still stays. And then she's back to square one. Now, the whole family is against this woman. So this woman is fighting the disease, the pain that she's suffering from, and the family, her own children, her own husband, who are supposed to be close to her. And they say that the investigations are normal. The doctors feel that you have no disease, and still you're behaving like this. So imagine the plight of this woman. And then she goes to a urologist. Now, the problem is that in urology training, I've had a training from the All India Institute of Medical Sciences, Department of Urology, from 1991 to 94. I was there. So we were taught that this disease does not exist in India. So that was the situation, because we believed, when we grew up as urologists, when we were trained as urologists, we were made to believe this disease does not exist. So how a urologist is supposed to look at a disease like this. So they will, and most of the training time in a urology department, the trainees are trained to treat cancers of the bladder, prostate, kidney, stones in the bladder, stones in the kidney, and other urinary diseases. And very little is focused during the education on this subject of interstitial cystitis. As a result, they are at a loss. Even if they do a cystoscopy, and many of them do it under local anesthesia, which I think should not be done. So if you're doing a cystoscopy, you don't find anything. So because your eyes will see what your mind knows. So you say it is normal. So now the family is convinced the patient has gone to a GP, she's gone to a gynecologist, she's gone to a urologist, and there is no diagnosis. That means this patient is really a troublemaker. And then she's referred to a psychiatrist, or maybe black magic, maybe chhad-phook in Indian context. And that is really a miserable situation. Imagine somebody who's actually having pain, going to washroom, is not able to sleep at night because she's to visit washroom 10 times at night. And she is being labeled as a psychopath and being treated by a psychiatrist or black magic or something like that. So these patients develop what is called suicidal tendencies. They are depressed. They actually then start behaving like that. So this is the clinical situation, and that is why the diagnosis is delayed in such patients.
So, sir, how does pregnancy affect these patients?
Yes, so pregnancy in some manner is supposed to reduce the inflammation of the bladder.
Okay.
So patients who have symptoms, and if they get pregnant, they have a complete remission of symptoms for at least 2 to 3 years. And we have seen those patients, and they will stop all medicines and they should be very fine till another 2 3 years. When the baby is almost 1.5 years or 2, typically they come back, and that is when they want to get some treatment again.
So what are the different diagnostic modalities that they need to undergo to be diagnosed with the condition?
Yes. So there are the diagnosis primarily is one of exclusion. So there is a clinical diagnosis which is supported with the cystoscopic diagnosis. So I will talk about each differently. So the clinical diagnosis is based on history, that if a patient has a pain in the lower abdomen or external genitalia or in the perineum or anus on full bladder, which is relieved on passing urine. So the key is it is relieved or reduced on passing urine, then perhaps we are dealing with bladder pain syndrome. Provided an additional thing which could cause these symptoms would be excluded. For example, if there is an infection in the external genitalia, a vulvitis infection, or any erosion or cervical pathology or pelvic inflammatory disease, or sometimes colitis, a localized colitis, because that also causes a pelvic pain, and movement of bladder can cause pain in them also. So that is the clinical diagnosis. The investigation, we need to do a urine routine examination. If the urine routine examination has pus cells, leukocyte esterase, or nitrite, it means that there is infection in the bladder. So presence of pus cells, nitrites, and leukocyte esterase means that this may not be interstitial cystitis. This may be an infective cystitis, and then we need to exclude that. Then the second is, of course, we do an ultrasound to exclude serious things. So sometimes I've seen patient having stone in the lower end of the ureter, a tube that drains the urine from kidney to bladder. So if there is a stone at the lower end of the ureter stuck near that bladder and the ureteric junction, that can give rise to pelvic pain. And that can sometimes mimic a pelvic pain of the urinary bladder. So we need to do an ultrasound to exclude this. The other thing is that in a country like India, where we have a lot of tuberculosis in the rural areas, a tubercular bladder will always present something like an interstitial cystitis. So many times patients have been referred to me as interstitial cystitis, but we have found tuberculosis of the bladder because that behaves exactly like this: the burning, pain, small capacity bladder, patient has to rush to pass urine, can't control. So all those things are actually also in tuberculosis. The only difference is that you will find plenty of pus cells in the urine, and you may find urinary AFB positive, the bacteria for tuberculosis, the Mycobacterium tuberculosis is positive in the urine. And of course, once you have done all these, you do a cystoscopy. Cystoscopy should be done under general anesthesia. And when you, because bladder it is painful bladder. So when you are filling, when you do cystoscopy, you are filling the bladder with an irrigant. So when you fill the bladder with an irrigant, it will cause pain. So if you're doing it under local anesthesia, you are giving pain to the patient. So you do a cystoscopy and you look at the bladder. If the bladder is, if the bladder is normal, the patient may still have bladder pain syndrome. But to make a diagnosis of interstitial cystitis, you will need to look at Hunner's lesions. So lesions are lesions which are star-shaped lesions, centered in radiating parallel capillaries, and they are very typical. Once you see them, you will never miss. But at the same time, I'll repeat my sentence that if your mind doesn't know, your eyes will not see.
Eyes won't see.
So you will have to look at that once at least. And once you have understood how it looks like, you will never miss it. So Hunner's lesions are hallmarks of interstitial cystitis. Now, bladder pain syndrome can have bladder-centric diseases and non-bladder-centric diseases. So if the cystoscopy is normal, it is a non-bladder-centric disease. If the cystoscopy has Hunner's lesion, then it is interstitial cystitis. Then there is a category in the bladder where when you distend, you will find bleeding spots. The bladder starts bleeding.
But I was just about to ask this, that you have blood in urine in this condition?
That is called raining of blood when you do cystoscopy. So it rains blood from all sides. So that is also a disease. That means that the bladder is diseased. But to call it interstitial cystitis, we need to have Hunner's lesion. So these diseases of bladder could be, some inflammations in the past or some inflammations which are going on, which we have not caught. But yes, they will be benefited by what is called hydrodistension. So before I take them for cystoscopy, what I do is, like I said, in pelvis, in a woman, you would have bladder, you would have uterus, and then you would have rectum. Right. So the pain can come from any of these.
Anywhere.
What we do is we pass a small infant feeding tube or a celastic catheter into the bladder in the office itself, and you put in lignocaine, 2% lignocaine solution. The pain coming from the bladder should immediately disappear within, say, minute or so. So that is called lignocaine test. And we published this, under my name in 2007, in 2010 in the European Urogynecology Journal. So we do that also. We do a cystoscopy and we do a biopsy. Sometimes there is a surprise. We think that this is a bladder pain syndrome, but when you take a biopsy, it shows either a fungal cystitis or a tubercular cystitis or carcinoma in situ. So we have seen all of them when we are doing a cystoscopy. So cystoscopy becomes an essential part of diagnosis as well as treatment. Because when you're doing a cystoscopy under general anesthesia, you can distend the bladder. We call it hydrodistension. So imagine a bladder which has not been filling because it causes pain. So the bladder has forgotten how to fill. So when we put it under anesthesia and we distend it like a balloon, then the bladder has the chance to get distended for a first time, maybe in years. because it would cause pain and the patient would not allow the bladder.
Not allow it to fill up at all. Just go and void it out.
Yes. So what happens when you distend the bladder, the nerve endings which are causing pain, they are disrupted. So the pain immediately disappears. So when the patient wakes up from anesthesia, if you have done a hydrodistension in a bladder-centric bladder pain syndrome, you do a hydrodistension, there is disruption of the nerve endings causing pain, and the pain disappears immediately. And the bladder capacity also increases. So when the patient wakes up from anesthesia, they have good bladder capacity. And the pain is disappeared. Yes.
Pain has disappeared. So is this a progressive condition?
Progressive, yes, it is. So I will tell you, I just seen one patient who is just 1 year history. So he is very quick. He is from Hyderabad. So he's picked up the diagnosis from the net, and he realized that he needed me. So he's come, we done a cystoscopy, and my whole team knew it. They said, sir, it is such an early disease. We had a good bladder capacity, but there were initial stages of disease. So maybe we can arrest this disease. But patients who come to us, they come to us maybe after 10 years of their initial symptoms, 8 years, 10 years, 12 years. And the literature says that the pain, the diagnosis takes almost 5 doctors on the average, and maybe an average of 7 years of suffering before the diagnosis is made. So it is a progressive disease. By the time patient come to us, the bladder has been inflamed, has become scarred due to inflammation, has forgotten to distend, and the bladder capacity is hardly 50 cc, 50 ml. So imagine if the patient is producing 2000 ml of urine in 24 hours, and the bladder capacity is only 50 ml. So she's going to washroom 40 times in a day to clear the 2000 ml. So that is how these bladders become defunct. So these patients, we call it end-stage bladder disease. Like we have end-stage renal disease. This is end-stage bladder.
Renal disease.
Yeah, so this is end-stage bladder disease. So if there is an end-stage bladder means it's a thick-walled bladder which has a capacity less than 100 ml, which cannot be distended under anesthesia. It is actually a useless bladder for the patient's perspective, because it is not supposed to, the bladder is supposed to store. This bladder is not able to store. So that means this is not useful to the patient. So we have two choices. If the patient has pain and you do augmentation cystoplasty, like we do it in tuberculosis, we can do an augmentation cystoplasty. But in interstitial cystitis, end-stage bladder, there is pain. So if you do an augmentation cystoplasty, the pain does not. So what we do in such patients is we remove the bladder and give them a diversion, urinary diversion in the form of an ileal fluid. Because if you leave behind the bladder, there will be a pain again. So I've been doing this, and I realized that there was one patient whose bladder was removed, and he kept complaining that he had pain in his bladder. So that is called phantom pain, like you have in a case where there is a limb which has been amputated. The patient still has pain in that limb. That is called phantom pain. Similarly, we had a real person whose bladder was removed, and he kept insisting, no, he has pain and he has a sensation to pass urine, where there was no bladder. So that was the kind of fixation. So we call it central neuroplasticity. So the brain has been conditioned with this kind of a signal, and the patient had a neuroplastic pain that persisted for at least 3 years before he finally got over it.
So what rescue solution?
Rescue solution. So yes, it is very important. So if the patient comes to us in the initial stages or not in the end stage bladder disease, what we do is we do repeated hydrodistensions We do ablation of
Okay.
the Hunner's lesions, and we instill steroids into the bladder. So what I instill is hydrocortisone and a solution of heparin, hydrocortisone, and that works well. So my patients, they receive this intracycle treatment once a week for 6 weeks. And then they are taking medication like pentosan polysulfate, which is an oral medicine. And depending upon if there is a history of allergy, I add hydroxyzine, which is an antihistaminic. If there is a neuropathic pain, then I add tryptomar to them. If there is a pelvic floor spasm, so a lot of these patients have a spastic pelvic floor. The literature says that up to 87% of patients with bladder pain syndrome may have a spastic pelvic floor. So you need to relieve the spasm of the pelvic floor. So the way is to give clonazepam, or sometimes in Europe, they give diazepam suppositories. We don't have diazepam suppositories in India, so I give clonazepam oral. We also give something like cyclobenzaprine, which is a skeletal muscle relaxant, which is available and is used by the orthopedic surgeons, and they will help. These patients would be helped. But only thing is that it is not only the medical management, it is more important to educate the family. Tell the husband, tell the mother-in-law, tell the children that she's not psycho. This poor lady has been suffering. So education of the family. So our motto of 2021-22 was save a bladder, save a family, because this is very important. We have seen that happen. So education is very
basically
important.
the caregivers also have to be educated.
That's right. The second is the diet. So we have understood that the diet in these patients can cause flares. For example, the spices, some of the fruits, some of the, some dark chocolates, and a lot of other things. So we realized that we have these patients who can have a trigger or a flare of pain with certain dietary changes. So what we did, we collected our patients and we had a survey. I got a dietitian with me and we chatted with them for 2-3 hours, got their inputs, and finally we have written a book. So this is the first book in the world, Indian Diet for Interstitial Cystitis. So we released it in 2019. And the second book came from Israel the same year, 3 months after independently we had done it. And in 2019, November, they released it in Amsterdam meeting. So we have an Indian diet. So diet becomes very important. It's extremely important. Then patients who have pelvic floor overactivity, they need physiotherapy. And that is very essential.
That is very essential.
Yes. So you have to have what is called pelvic floor relaxation exercises. Unfortunately, those who are not well versed with the condition, they will teach them Kegel exercise to hold urine. So that does an opposite job. I'm trying to relax the pelvic floor because there is a fight between the bladder and the sphincter. The sphincter doesn't open. And if she comes back with Kegel's exercises, then my disease is getting worsened. So we had kind of workshop for the physiotherapy, and many people from all over the country came, physiotherapists, only for physiotherapists for bladder, for the physiotherapy for bladder pain syndrome. And it focused on pelvic floor relaxation exercise.
Right.
The right approach, not the Kegel's exercise. So it is the diagnosis, the education, the diet, the physiotherapy, and of course, constant talking to the patient. So what we did is we created patient groups, support groups. So what I did was, because there are certain patients who have been with me for say 12 years, 15 years, there are certain who have just joined in maybe 3 months. So we have a WhatsApp group and we have a Facebook group also. So they will keep chatting with each other. For example, I can't tell them what diet, suppose somebody has a problem with a particular diet. So she puts it into the group. Then others also will recognize, okay, yes, I also have a problem. So that is the biggest advantage. Other advantage is that once you put them into the group, the family also understands. So there are hundreds of these patients. Our patient is not the only one. Yes. So they understand that it is a real condition, it's a real problem, and they keep, keep themselves chatting amongst themselves and keep their morale high. Because what happens is if they are alone, they can go into depression. So I've seen what they do is they can pull up each other's morale now and then, and they become very good friends, some of them with each other. And we generally try to have them get together and have an icy special meal when we get together. So these are the things which we keep doing because these are important. Just making a diagnosis or writing a medicine doesn't work.
Doesn't work. Very correct.
You have to educate the family. You have to educate about diet. You have to educate about physiotherapy. You have to get them together because I can do a very limited work with the patient or the family. But families themselves can support themselves and make a pyramid. That's how. So what we did was we started International Interstitial Cystitis Bladder Pain Syndrome Day, ICBPS Day.
Okay.
So we started it as the first Sunday of March.
Okay.
So starting from 2021. So 2022, we had the second ICBPS International Day, and we had patients from almost 20 countries participating as a Zoom meeting. So we had it as Zoom, and on that, we encourage only patients will speak, no doctors will speak. Okay. The doctors will be there as audience, and the patients would speak. So we invited them, and this time we had 10 people who wanted to speak, and they spoke about their stories. Okay. And we told them that you should not name any doctor or the hospital, just tell your story because it may not be ethical to talk about one doctor's practice in presence of others. So it is the International Patients Day that we have started, and we had the second one, and we had almost 20 people, 20 countries participating. So it is going to be, so this is a big movement that we started. We started it in 2016. I'm the founder chairman for that, and that is Global Interstitial Cystitis Bladder Pain Society, GIBS. So we used to have annual meetings, physical meetings till 2019. Then 20 and 21, we had webinars, and we had participation from 37 countries all over the globe. So it is a truly global society now. We started with 8 people in Mumbai in the April 2015. We started with 8 people, and now we have a whole organization, and we have participants from 37 countries across the globe. So this is truly a global.
Incredible, sir.
Yes, and we keep having webinars. Okay. So we have GIBS webinars, at least 1 to 2 webinars per month. And we have, what we do is we get people from cities, for example, Baroda, Kanpur, Panipat, Sonipat. So there will be a gynecologist and a urologist, and we collaborate with them. They get their local IMA involved, and we have a Zoom meeting, and we have lectures from the local faculty as well as GIBS faculty. And we have done in the last 2 years, in starting 2020, we were doing almost 1 to 2 webinars a month. And we have obviously the annual meeting. So we have the next annual meeting, which will be the 7th annual international conference. This time it is going to be in Mumbai, physical, and it is going to be in August 27th and 28th. Okay. Yes. And we are looking forward to participation from the international faculty.
That's great. It's really great, sir.
Yes. So it is a subject very close to my heart. And it is because we were taught that it does not exist in India, but I realized it does exist and there are patients who are suffering. So we had to do this. And I wrote a book in 2014, we released it in Delhi about interstitial cystitis. I wrote it because I thought whatever I have learned, it should not die with me. So I started with that book, and then we got 8 people together. Fortunately, everybody was very keen to progress on this.
Okay.
And now it is like it's like a cascade. So every city has a GIBS movement. So they have learned, we have webinars, 2 hours webinars. So any urologist or gynecologist wants to have a GIBS meeting in their city, we can do it through Zoom and collect their IMA, and we go ahead, and that's how it's a very satisfying job, because now I have 3 layers of speakers. I don't have to speak every time. So the faculty of the GIBS, that is the beauty. The faculty of the GIBS takes care. So we have got 20 faculty people now,
okay,
are qualified, who have been experienced, and they can speak on interstitial cystitis anytime in any meeting. So that is how it works.
Educate all doctors around.
That's important.
That's
It
important.
was extremely important for us to do that.
That's really, really wonderful, sir. And I think we've had a very, very informative and interactive session, sir. I'm sure the audience is really, really going to benefit from our session today.
Good. Thank you very much for giving an opportunity.
Sir, in fact, I want to thank you for sparing your valuable time and coming up on the platform. It's been a wonderful session.
Oh, thank you very much, Dr. Gulshan. And you have my, you can, if anybody who wants to know about this disease, or wants to have a webinar or a seminar, our organization will take care of it. Don't worry. Our aim, the aim with which we made this organization was to educate.
Right, sir.
Education at the GP level, at the urology level, gynecology specialist level, and at the public level also. Because patients also sometimes, like in US, the person would go to the doctor and tell him that, look, maybe I am suffering from interstitial cystitis. But that is not there in India. We are far behind as far as the masses education is concerned.
Very true, sir.
So our mission is to educate at 3 levels: the masses, the patients, and the doctors.
Right. Thank you so much, sir, for being here with us. It was a great pleasure to have you with us, sir.
Thank you very much. The pleasure is entirely mine. Don't worry.
Thank you, sir.